followed by a pause. This is a real key. One of the hardest things that people have in diagnosing rhythm strips is second-degree AV block. And if you see groups of complexes followed by a pause, that is always second-degree AV block until you can prove otherwise. So that eliminates a lot of dysrhythmias right off the bat. So when you look at something like this, you go, hey, that's pretty well organized. The patient may be dying, but the electrical activity in the heart looks pretty good, as opposed to something like this where you say, I bet you that patient is dying, or else somebody didn't connect the leads to the machine. And you get something like this, yeah, the rhythm's very regular, but it's a bad rhythm. But it is regular, so there's some kind of organized activity going on there. And then you look at this kind of a thing and you say, wow, this thing is irregular, but there's a kind of a pattern to that irregularity. And then you look at this kind of a thing and you go, man, that thing's all over the place. What is that? That's an irregular rhythm. And whenever you see something like this, the first thing you always think about is atrial fibrillation until you can prove otherwise. So just by getting a feel for what's on the screen, you can actually get a diagnosis to pop in your head that then you can try to rule out or confirm. And then, like I said before, anytime that we see groups of beats followed by any kind of a pause, always think of second-degree AV block. So look for a P wave, and that's the reason why we use lead 2, because that has an upright P wave. And then what you can do is you can go between every P wave and measure that distance, and it should always be the same. Look at the R waves or the S waves in the distance, and they should always be the same if we're talking about normal sinus rhythm. So you see all these arrows. Those arrows identify P waves. And if I take a measurement between each one of those arrows, it's always fixed and constant. That tells me that I'm having atrial activity. Then look at the QRS complexes. First off, are they narrow or are they wide? So are they coming from an impulse in the atria, or if they're wide, are they coming from an impulse in the ventricles? And they all look the same. That means they're all coming from the same focus. And then is the ventricular rate the same as the atrial rate? When you start to put all these things together in an organized fashion, then you can get an idea as to what is going on in that tracing. So again, all those arrows show that there are P waves. And the distance between every P wave is the same. And then we measure the distance between every R waves, and they're all the same. And then you say, hey, what about the P waves and the R waves? Are those distances the same? And they are. So if I take this measurement, that's the same as this measurement. That always makes you think about sinus rhythm. When the atrial activity is equal to the ventricular activity, there's a P wave in front of every QRS complex, sinus rhythm. And then we want to see if what's going on in the atria is reflective of what's going on in the ventricle. And that's going to be determined by your PR interval. And then finally, what's the heart rate? Is it fast? Is it normal? Is it slow? And you can either look at your monitor, or if you don't have a monitor, you just have a strip. There'll be these little lines on here, that's 3 seconds. So just count the number of beats in 2-3 seconds, and multiply that by 10, that gives you your rate for a minute. Or you can use this 300 to 150, 100, 75, 60, 50 kind of device to give you an estimate of what your rhythm would be, what your heart rate would be. And then finally, is the rhythm regular, irregular, or irregular? By this time, you should get enough of information to kind of come up with a diagnosis. So, when you look at, that didn't work, it shouldn't have come up that way, but when you look at something like this, the first thing you go is, wow, hey, that's a pretty regular rhythm. But then you look at those QRS complexes and you say, ooh, that's not good. They're wide. Is this ventricular tachycardia? Well, okay, ventricular tachycardia shouldn't have P waves. So then go back and try to find P waves. And lo and behold, there's a P wave, there's a P wave, there's a P wave, there's a P wave, there's a P wave. Then measure the PR interval to see does this cause this. That's a fixed distance, that's a fixed distance, that's a fixed distance, and they're all the same. So this beat here in the atria is causing this complex to form, and it's just giving you a wide QRS complex. That's basically a bundle branch block. But it's a supraventricular rhythm. And then what's the clinical significance of the rhythm? That's the ultimate thing. You know, you can have something that looks perfectly normal, but the patient's dead because they have basically the electrical system's working, but it's not producing a pulse. So what's the diagnosis? Do we need to provide any treatment for it? So let's start to look at some of these rhythms, and then we have some test strips to go over, and we'll go over those one by one. But things that are regular tend to occur up into the sinus. So you have normal sinus rhythm, sinus bradycardia, sinus tachycardia, atrial tachycardia. Junctional rhythms, they'll also be regular, but you won't see P waves. Ventricular tachycardia, for the most part, is pretty regular, but it's coming from the ventricles. Some of the blocks that you'll see, first degree AV block is going to be a very regular rhythm. So is third degree AV block. Things that are irregular, the first thing you always think about is it has to be a premature complex. Okay? Anything that's premature will cause an irregular rhythm. And then groups of beats, we're always going to look for second degree AV block. If it's irregularly irregular, that's a classic description of atrial fibrillation. So let's go into some of these. So normal sinus rhythm, all that means is that the heart's electrical system's working. It doesn't tell us if the patient's sick or healthy. So you're going to find a P wave, that's the atrial activity, and we use lead 2 because it's usually upright. The heart rate's going to be between 60 and 100. The rhythm is regular. So if I map out every P wave, it's all going to be the same rate. If I map out every R wave, it's going to all be the same rate, and this is equal to this. The P wave is going to have one shape, if it's in lead 2, every P wave is going to look the same. If you look at lead 3, every P wave in that lead is going to look the same. The PR intervals are fixed. There's a QRS complex that follows every P wave. And that's what we have here. So we have a P, QRS, T wave, P, QRS, T wave, P, QRS, T wave. If we measure the distance between each P wave, it's fixed. If we measure the distance between every R wave, it's fixed. The rate for the atria is equal to the rate of the ventricle. The QRS complex is narrow. That makes it sinus rhythm. In sinus bradycardia, the only difference is the rate just gets slower. Sinus tachycardia, the only difference is the rate gets faster. But there's a P wave before every QRS complex. Premature beats. There's something that's going to happen earlier than when it should. So it gives you an irregular rhythm. Now sometimes that premature P wave can be right in front of the QRS complex, and depending on where it is in the atria, sometimes it can actually be buried in the T wave. But one thing that it does produce, it produces a pause in your rhythm, but it's not fully compensatory like a PVC. Your QRS complexes are usually normal. So what do we have here? So if we take the measurement from here to there, that distance is the same. There's a P wave, a P wave, a P wave, and then there's this funny looking P wave right there. And this occurs earlier. So that's a premature atrial complex. Why? Because the P wave is different shape than this. It occurs earlier than it should. It produces a QRS complex that's narrow. And there's a pause after it, but it's not compensatory. So if I take a ruler and measure here to here to here, that distance is going to be greater than the distance from here to here to here. So this is not a fully compensatory pause like you would see in a PVC. So it's incomplete. There's a pause in the rhythm, but it's not a fully compensatory pause. Now PSVT, some of the things that you may see when you give somebody too much epinephrine, You can develop a very, very fast rate, but a regular rhythm, or it can be a disease state. Basically, you're just having a very, very fast heart rate. You don't see P waves when it gets very fast because there's not enough of room on the graph paper, so they're buried in that QRS complex. And the QRS complex is basically very narrow. And treatments of those things, you know, you could use vagal maneuvers, you could use adenosine, you could use a calcium channel blocker to slow that rate down, you could use a beta blocker to slow that rate down. But you look at this and you first off you go, hey, that's pretty regular to me. And then you try to find P waves, and you really don't see P waves. You just see these big, long, spiked T waves. But it's a very, very regular rhythm. It's a fast rate. There's no P waves. The QRSs are narrow. That's a sign of some type of sinus tachycardia. And if it's fast enough, it's basically a paroxysmal supraventricular tachycardia. Now with atrial flutter, we don't see P waves, but we're going to see what we call flutter waves. And it's going to be a sawtooth appearance, especially in lead 2. All right? And it's a diseased heart. You don't see atrial flutter in a healthy person. So you look at this, and in this case, the rhythm is regular, but you see these squiggly lines here that, if you use your imagination, it kind of looks like a saw blade. And all of these things, if you measure from the peak of there to there to there to there, it's all equal, okay? So those aren't T waves and some abnormality. Those are actually flutter waves. And in this case, again, a sawtooth appearance. Now, the rhythm is irregular because there's heart block associated when you get these atrial flutters. And it depends on what kind of a heart block you have as to whether or not the rhythm will be regular. If somebody's on medications, they tend to have a fixed AV block. If somebody's not on medications, then they tend to be all over the place because these complexes just keep beating, and every once in a while it'll actually get carried down to the ventricle and you'll see a QRS complex. But you see these sawtooth patterns. Now, atrial fibrillation is we really don't see any real organized activity in that atria. In fact, if you look at the baseline, you just may see some squiggly lines all over the place, but the ventricular rhythm is just all over the place. You look at it and go, there's no rhyme or reason to anything that's going on there. And these people, they definitely have a diseased heart. This is the most common dysrhythmia that you'll see in the elderly population. And you look at this, it's all over the place. There's no fixed pattern to the distances between any of these S waves. And then if you look at the baseline, it's all squiggly looking. That's atrial fibrillation. What about ventricular rhythms? Well, a premature ventricular complex, just like an atrial complex, means that it's some beat that happened earlier than when it should. So when you look at the rhythm, there'll be an early beat that looks kind of bizarre looking. The QRS complex is very wide. The ST, and this is another sign for a PVC. The major deflection of the QRS is always 180 degrees opposite to where the ST segment T wave is. And I'll show you what that is in a minute. But there's a compensatory pause here. So if we take the measurement of 3 normal beats, that distance will be the same as the distance between a normal, abnormal, and normal beat. So this is what we're talking about. So you take 1, 2, 3, that distance, and then if you look at this abnormal beat, if you go from here to here to here, that distance equals this distance. That's a fully compensatory pause. And why does that happen? Because when this premature ventricular contraction occurs, it shoots electricity in both directions. It shoots it back to the atria, and it shoots it forward to the ventricle. So when it goes forward to the ventricle, you get this big, wide-looking complex. When it goes back to the atria, inside this area, there's actually a P wave from the atria. So the SA node fired, and that's why you see a compensatory pause, because if you measured the distance between every one of these P waves, there would be a P wave hidden in here. So the SA node does fire, but it can't produce a beat. And that's why it's compensatory, because the SA node fires, unlike in a premature atrial complex where the SA node cannot fire. And so you look at these, you get these abnormal looking beats. This one doesn't look too wide, but I said the major deflection of the QRS, in this case it's an S wave, is always 180 degrees opposite to the STT wave. So if this is down, this has to be up. If this is up, this has to be down. And it's a wide beat. Here, this just happens to be two of these things occurring in a row, so that's called a couplet. Again, a premature beat, it occurs earlier than it should. You don't see a P wave because it's hidden inside here. There's a wide QRS complex. The major deflection is always 180 degrees opposite to the STT wave. This is two PVCs occurring in a row. This is three of them occurring in a row, and they all look the same. That means there's the same focus. Somewhere in the ventricle, there's a hot spot that's causing these beats to occur, and it's the same hot spot because they're all the same shape. And the problem is if one of these occur in a critical area of the ventricular recovery cycle, it'll set off a bout of ventricular fibrillation. Now this is probably the most difficult part for people to identify is heart blocks on here. Now heart blocks just mean the P wave falls outside of the QT interval of the previous beat and it produces one of these things. Either the PR interval is just increased, so it's greater than 0.20 seconds, so it's a first degree AV block, or you see a P wave, but there's no contraction to the ventricle, all right? Or it's there is you see a P wave, and it doesn't go to the ventricle, so it's blocked. So you have different types. You have first degree, second degree, and there's two types of those, and then for the most part, you're just looking at third degree. So let's look at some of the criteria for these things. If you have a first degree AV block, the rhythm is going to be very regular. You're going to see a P wave before every QRS complex, but the PR interval is going to be greater than this 0.20 seconds. Every P wave has a QRS complex. The QRS complex is usually normal, and if you measure the distance between every P wave, it's going to be fixed, and it's going to equal the distance between every R wave. So what's that look like? So if we measure the distance between each one of these P waves, that's equal to the distance between each one of these R waves. The only thing abnormal here is the PR interval is increased. That makes it a first degree AV block. Now with a second degree AV block, we have two kind of phenomena that can happen. The so-called Mobitz 1, where it's just an abnormality in refractory periods. And then you have this Mobitz 2 that is a diseased heart where there's some kind of pathologic condition that won't let what's going on in the AV node to go down to the ventricle. So let's look at this. And again, this is probably the hardest part. The atrial rhythm is usually coming from the SA node or somewhere else in the atria. It's usually sinus, but sometimes it can be atrial tachycardia. The ventricular rhythm is irregular. So you have a very regular atrial rhythm, but an irregular ventricular rhythm because you get these groups of beats. If you look at the PR interval, there's going to be a progressive increase in the PR interval until you see a P wave where there's no conduction at all. And then there are some other criteria that you can use to try to fine-tune this diagnosis, and that is that the PR interval after the P wave that's blocked is always going to be the shortest, and the second PR interval is always going to have the maximum increase. The PR intervals increase, but the RR intervals actually decrease, and I'll show you that. So you see groups of beats, and this is what we have. So if you count the number of blocks on something like this, first off, if you look at the rhythm, you see beat, 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 pause. So there's a group of beats. Beat, 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 beat. That doesn't help you. If we count the blocks between every P wave, all right, so if I take the distance from here to here, or the distance from here to here, there's 100 blocks, and it's all fixed. So that means the atrial rate is regular, it's not changing. So every P wave maps out, P to P to P to P to P. And then if I take the number of blocks for each PR interval, what happens? The first one is 20, the next one is 32, the next one's 40, 44, and then you have a P wave that doesn't conduct. So the PR intervals increase. Now, what about the RR intervals? I said they got less. So if you count the number of blocks here to here, it's 100 plus the 12. This one is 100 plus another 8. It gets smaller. This one, there's 104. And so the RR intervals decrease. And then if you look at the area between this QRS complex and this QRS complex, there's 176 blocks. It's not a multiple of here. So if that were to be a multiple, this should be 200. So that's some of the criteria. In a second degree AV block type 2, this distance will actually be a multiple of this. So with a second degree AV block type 1, what happens is this. The atrial rates are very regular. They're fixed. The PR intervals increase until you get a P wave that doesn't conduct. The RR intervals progressively decrease, and the area that contains the blocked P wave is not a multiple of the basic PP cycle. So you look at this, and you see a group of beats here and a pause, and then there's a group of beats over here. P, 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 but no wave. PR interval here, this increases, this gets even further increased, you have a P wave that drops. So the distance from here to here to here to here is always the same, it doesn't vary. The distance from here to here is greater than the distance from here to here, so these RR waves get shorter, and the distance from here to here is not a multiple of the basic atrial rate. Now what happens in the second degree AV block? For the most part, in the very beginning, it looks just like a second degree block type 1. The PR interval, though, is constant. It doesn't change. And then you'll see a blocked P wave, but there's no Winky-Bach phenomena. The PR interval is fixed. The RR interval with a blocked P is a multiple of the basic PP cycle, so there's no shortening of your RR intervals. And that's what's happening here. So you see a group of beats, 1, 2, 3, P wave and it drops. 1, 2, 3, and a P wave and it drops. If I measure this PR interval, it's fixed. It does not change at all. And then you'll get a P wave with a drop beat. If I measure this interval here, that equals this interval. If I measure this interval from here to here, that's twice this basic RR interval. So that's the difference between a second degree AV block type 1 and a second degree AV block type 2. Now what about a third degree AV block? Basically what's going on in the atria has nothing to do with what's going on in the ventricles. These two things are beaten independent of each other. So if you just look at the ventricular complexes, it'll look like a very, very regular rhythm. So the rhythm from the atria is very regular, the rhythm from the ventricles is very regular, but the atrial rate is always going to be faster than the ventricular rate. There is no such thing as a PR interval, and when you put all that together, it's called AV dissociation, meaning what happens in the atria has no influence of what happens in the ventricle. So you look at this rhythm, and it looks very regular. The distance from here to here to here to here to here is all the same. Then I look for P waves. Well, it goes, here's a P wave, and there's a P wave. Hey, but there's a P wave too. So you back it off, and you say, hey, this thing here doesn't look right. So what happens is you have a P wave hidden inside of a T wave, P wave, P wave, P wave, P wave, P wave. So that P to P interval is fixed, and it's faster than the RR interval. There is no any fixed correlation between the PR intervals. When you see that, a regular ventricular response, a regular atrial response, where the atrial rate is greater than the ventricular rate, that makes it a third-degree AV block. Again, something that looks regular. The distance from here to here to here to here, they're all equal. And then you have to find P waves. Well, there's one there, 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 there's one right there, one there, one there. And if you measure those intervals, they're all fixed, but this P wave rate is faster than the ventricular rate. That's a third-degree AV block. Okay, so let's try to put this into practice. So, would everyone agree that that looks like a regular rhythm? Pretty regular to me. The ventricular rate is 75, and the atrial rate is 75. So they're the same. Each P wave has a QRS complex. The PR interval is fixed. The QRS complex is normal. What's the diagnosis? Sinus rhythm, yeah. So it's normal sinus rhythm. Now, what are the third and fifth beats? So we have a PQRS, something that looks goofy here. PQRS, something that looks goofy here. PQRS. So if you look at this, that's all regular. If you look at this, this is irregular. So the first thing you think about with irregularities is a premature beat. So if you're looking for a premature beat, the first thing you want to see is there a P wave? Yes, there is. It's right here. And this P wave is different looking than this P wave or this P wave. There is no compensatory pause. So if I take this measurement from here to here to here, that's less than the distance between three normal beats. Funny looking P wave, a beat that occurs prematurely, a normal looking QRS complex, a non-compensatory pause, that makes this what? A PAC or a PJC. Something either coming from the atria or coming from the junction, but it's certainly not a PVC. All right, a very regular looking rhythm, but it's just fast. The atrial rate is 130, the ventricular rate is 130. You look to try to find P waves. You see one there, one there, one there, one there, one there. You measure the PR intervals, they're fixed. The QRS complex is normal. It's a fast rate, a regular rhythm. P wave activity is normal, QRS activity is normal. What's this kind of a diagnosis? Sinus tachycardia, because you see P waves. So it's sinus tachycardia. If it was faster and there were no P waves, it would be a supraventricular tachycardia. Now, you look at this, and you go, hey, that looks like a pretty regular rhythm, but look at all these squiggly lines over here. So that looks like your sawtooth kind of an appearance thing, correct? So there's no P wave activity here. These are flutter waves. So the diagnosis there would be what? Atrial flutter, yeah. Now, you look at this, and you see groups of beats. There's 3 and a pause, 3, 2 and a pause, and then another 3, and well, we don't see the QRS complex. But a group of 3 and a group of 2. So whenever you see group beats, you start to think immediately about second-degree AV block. So next thing you want to do is look and find a P wave. There's one there, one there, one there, one there, one there. The PR interval, this distance is the same as this distance, is the same as this distance, but there's a P wave and it drops. So the PR intervals are fixed. I then take a measurement between these two QRS complexes. The distance from here to here is the same as from here to here. The distance from here to here is twice this distance. That makes it what type of second degree AV block? A type 2. Why? PR interval is fixed. A P wave that drops. This distance is a multiple of this distance. That makes it a second degree type 2. So now we have something that, hey, that looks pretty regular. So now I want to try to find P waves. And I see one there, one there, one there, one there. There's one hidden in there. There's one there, one there. There's no fixed pattern to the PR intervals. This rate is faster than this rate, but the rhythms are regular. What do you think's going on there? A third degree AV block. Why? Because the rhythm is very regular. The atrial rate is faster than the ventricular rate. There is no set pattern to the PR intervals. That makes it a third degree AV block. Okay? Now you look at this. You have something PQRS, 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 something bizarre looking there where that arrow is. And you get 1, 2, 3, 4, 5, 6, 7, 8. 8 beats, 8 complexes that all look the same, and then, boom, complexes that look a little bit different. Why do they look a little bit different? Because I can see P waves here, I see no P waves there. So what do you think happened here? What do you think is going on? It's a pretty fast rate, right? It's supraventricular. Why? Because all these QRS complexes are narrow. So in the beginning here, we have a PQRS, PQRS, PQRS. There's a fixed PR interval. The QRS complexes are normal. This part is normal sinus rhythm. But then, all of a sudden, something happens early. There's a premature beat because this distance is shorter than this distance. And I look to say, well, that's a premature beat. What kind of premature beat was it? Well, I find a P wave. It occurred earlier than normal. The QRS complex is narrow, so that meant that this was a PAC. But then all of a sudden, since it hit in this vulnerable period, this is called the relative refractory period, this prematurity set off a 1, 2, 3, 4, 5, 6, 7, 8 complexes of a very fast rhythm. What do you think that fast rhythm is? There's a P wave before each one of these, right?
SVT.
It's a fast rate, a regular rhythm, narrow QRS complexes. That means depending upon how fast it is, it's either a sinus tachycardia or atrial tachycardia. And then what happens over here? It even gets faster. And when it gets faster, you don't see any QRS complex, any P waves at all. So that breaks down into a PSVT. So we have a system where we had a normal sinus rhythm, we had a premature beat that set off a run of atrial tachycardia because the rate's faster than 160, and then that lasted for 8 complexes, and then you lost the P waves, and you have 5 complexes of PSVT. That's very similar to what happens when you have a premature PVC that occurs on that relative refractory period, but instead of causing PSVT, it'll cause either ventricular tachycardia or sometimes ventricular fibrillation. Okay, now, does that look regular? I'd say yeah. Is it fast?
Yes.
Yeah, it's fast. Do you see P waves? Yes, I do. One there, one there, one there, one there, one there, one there. Does each P wave have a QRS? Yes, it does. Is it a supraventricular rhythm or a ventricular rhythm? Supraventricular. Okay. You may see P waves in some of the complexes, but you don't see P waves in all of them. So basically, you could just junk it all together and call it a PSVT. Does that look like a regular rhythm or an irregular rhythm?
Regular.
It's pretty regular, but it's also pretty slow. So you say, okay, this joker showed me all these slides of third degree AV block, so I think that's what it is. Well, okay, prove it. Well, find P waves. So you find a P wave, a P wave, a P wave. The PR interval distance from here to here is the same as here to here, here to here. So this is a set pattern to the PR interval. This just makes this sinus bradycardia. You see that? So sometimes you try to interpret too much into these things, and you're looking for disease when in fact it's not disease, it's just normal, it's just a slow rhythm. All right, this is irregular, right? Because you have these funny looking complexes here that occur earlier, because if you have this distance, this is certainly shorter than this distance, so it's a premature contraction. So it's an irregular rhythm. Is there a P wave before this big balloon here? What is it? I don't know. You got a wide QRS complex. I don't see a P wave there at all. I don't see a P wave there at all. But the major deflection of the QRS complex is 180 degrees to the STT wave segment. I have a wide QRS, in a premature beat, and then I say, okay, well, is there a compensatory pause? So I take this measurement of these three, compare it to these three, and they're equal. So we have a compensatory pause. So here's the facts. We have no P wave, a wide QRS complex. The major deflection is 180 degrees opposite to the ST segment. There's a compensatory pause. That makes that premature beat a what? A PVC. Right. Okay, what do we have here? Okay, I heard somebody say groups first. All right, groups, yeah. So we have groups of beats. A group, no, we can't use that. So we have groups of beats, so look for the P wave. P, 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 nothing. Okay, PR intervals. One increases even more, and then a P with nothing. If I look at these distances, this distance is greater than this distance, so the RR intervals are decreasing. I take this distance and compare it to this, they're not multiples. So what do we have going on here? We have a P wave before each complex until we drop a QRS. We have a changing PR interval. We have RR intervals that get shorter. The interval that contains the dropped QRS is not a multiple of the basic P to P range. That makes it a second degree AV block type what?
1.
Type 1, yeah. Whoop. And then that. Oh, well, I screwed that up. Okay, so it's a fast rate. Obstructive sleep apnea. Yeah, that's it, yeah. That's me in the middle of the night. Ventricular tachycardia. Okay, I'm not going to go through the rest of that because I'm just beating you. But the one thing I will tell you is all these monitors that they had out there, some people say, hey, can we look at ischemia on these heart monitors? And yeah, you can. On the old monitors that we used to have back in the 80s, we couldn't because we only looked at lead 2. But all those monitors that she had out there, you can actually get 5 leads on that monitor. And you can actually put a lead on the chest to try to look for ischemia. Now, do you want to do that? My personal opinion is this. Keep it simple, stupid. Is that how you say it? Yeah. Yeah, okay. The KISS principle. If you're really worried about a patient coming into your office having myocardial ischemia during an anesthetic, what should you do? You shouldn't do that patient, all right? So use a regular 3-lead ECG. If you want to use a 5-lead ECG, fine, but use it to monitor rhythms. If you're truly worried about ischemia, that patient needs to be referred to somebody that can take that to the hospital. Because even if you detect ischemia, what are you going to do? You can't treat it. The patient needs to have some more extensive cardiovascular procedure done. So I don't worry about ischemia. The only thing you really need to do is in patients that have bad hearts, you never let them become tachycardic, you never let them become hypertensive. If you let them have either one of those, you're going to precipitate ischemia. So if you avoid tachycardia and hypertension, those patients do not have much of a problem. So I thank you very much. And then Mark will finish this up and we'll get you out of here in another hour or so. I thank you for your attention.